Right, and I think we will start off with our case today. And Lauren Hayes is going to tell us about a case talking about persistent depression and sickle cell disease.
Hi, everyone. I'm going to share my slides and we can get going. So I was just asking if there were any mental health providers who would be attending. So I don't know my audience here. I presume mostly medical, but if there's any mental health providers, I'd love you to speak up as well. And I'm curious to hear all you medical folks and what you think about this case. So this, I'll start first with his medical history, with the caveat that I'm a pediatric psychologist here at Norton and U of L. So I do not deep dive into the medical aspects. My medical colleague is actually out unexpectedly. So forgive me if there are medical pieces missing. But he's an 18-year-old male with sickle cell SS disease, asthma, migraines, and allergic rhinitis. His migraines have been pretty persistent for the past year. He's frequently actually hospitalized for those, in addition to sickle cell pain crises. He was previously on red blood cell exchange for 2 years, and he stopped due to he decided against medical advice to stop doing exchange due to not wanting to have a port. He's a boxer and just didn't want to have a port so that he could do things like that. So in lieu of red blood cell exchange, he was started on hydroxyurea daily. He does have a history of poor adherence to clinic and red blood cell exchange visits. And also we know that he does not per his report, does not consistently take his medicine, and that's substantiated by our labs as well. He is actually in the midst of a pretty long hospitalization. He at first presented for a vaso-occlusive episode, and since then has had just a multitude of complications, including acute chest, multifocal pneumonia, and osteomyelitis. So it's been a pretty intense course for this hospitalization. There are the high notes with medical history. Regarding mental health history, I first came into contact with him back in the summer of 2024. And during that he had previously seen a sickle cell psychologist that we had maybe once or twice many years before, not been diagnosed with anything. When I met with him, I diagnosed him with persistent depressive disorder with anxious distress. So for those in the audience who are maybe not as familiar with this diagnosis, it's essentially dysthymia is what it was previously called. And it's different from major depressive disorder, which is more episodic in nature. Persistent depressive disorder is that most days in a month he will experience depression, whereas major depressive disorder, like I said, is more episodic. A couple weeks of major depressive episode and then kind of back to typical functioning for a couple weeks or months even. So persistent depressive disorder with anxious distress. So there's a significant increase of anxiety symptoms around particularly illness and his sickle cell and pain crises. So typically anxiety is not a concern for him, but it's more of the depressive profile. But with illness specific things, he does experience significant anxious distress. So that's what I diagnosed him with. I met him in the hospital. At that encounter, I also gleaned that he had a history of depression and emotion regulation challenges since early adolescence. There was no caregiver. There really is never a caregiver at bedside, so it's hard to get a good picture. But he was hospitalized at an inpatient psychiatric facility a handful of times between 13 to 15 years old. So he does have a significant mental health history predating when I met him. And that was confirmed in the records. So on that first encounter with him in the hospital in the summer of 2024, I recommended psychiatry to get involved and provide recommendations with his history of non-adherence to medical recommendations and clinic visits, I really hesitated to, I mean, I offered him the choice of therapy referrals versus psychiatry, and he chose psychiatry. And I also just think psychiatry is probably a more feasible option for our kiddos with a lot of barriers. So they started him on Cymbalta at that time, and he has continued to titrate up to 40 milligrams of Cymbalta. I do see him alongside his medical visits, so I've seen him several times in the hospital, a couple clinic visits, but primarily in the hospital. He's had quite a few pain crises over the past 6-8 months. About 17 encounters that I've had with him, not all unique hospitalizations, I guess, several times during a hospital visit. So a little bit of backstory on his family, because I think it is relevant. He has 6 siblings, so there's 7 children. Some half siblings and some full siblings. 6 of the 7 children have sickle cell disease. So I've now met all of his siblings who have sickle cell disease. From the family, just knowing the family dynamic and the other kiddos, I do know there is a history of witnessing gun violence within the family. One of his older brothers was shot due to gun violence and has now a colostomy. And so gun violence is very prevalent. I know that like attendance to medical appointments is really hard for the family. Transportation is inconsistent. So there's a lot of barriers to care, period, and then mental health care even more so. I've met mother multiple times with other siblings, and mental health is not something that's frequently, or emotions, dealing with difficult things is not frequently discussed in their family. So it's just not culturally normal for them to talk about mental health. So before I get into I have some specific questions for the group that I'd love to pick your all's brain on. Before I do that, are there any questions regarding this kiddo's mental health history?
Hi, this is Julie. So in terms of his previous psychiatric hospitalizations, were those for suicidal ideation, or were they for, hallucinations? What spurred those, do you know?
It was suicidal ideation. And I only have a limited availability to look into the record. I can see some very just summary documents. So I did confirm that he has had 2 hospitalizations. It was for suicidal ideation, depression.
And I think my other question is, does he want to get better?
Um, yes, yes. I have put in a lot of time. He probably knows me just as well as his sickle cell doctor that he's known for 18 years now. I have put a lot of time showing up and being a consistent person for this kiddo and all of his siblings, really. So he is really open with me about what's going on emotionally. He does have a very classic depressive profile of, it's hard to see how this could be any better, very hopeless about the future. He has so many barriers, and just the trauma that he's been exposed to, the lack of resources. I understand, but he does feel particularly hopeless about his sickle cell disease. He consistently said, "This is not fair." I mean, the sickle cell disease is a significant distress. It causes a lot of distress for him. Yeah, but he often will say, "This is not fair. There's nothing I can do to help this situation." And you'll see that's where some of my intervention is around.
And last question, which is medical, is he able to tell you if when he was on chronic transfusions, if he felt better?
I don't know. That's a great question. I'm trying to recall. There was a big clinic visit that we all took part, all the disciplines were involved when he said that he no longer wanted to be on exchange. I'm trying to recall back when that was and if we had discussed we're doing a trial period right now. So it was a 3-month trial period to see how he did off of exchange. He's currently in the hospital. It's the end of the tail end of the 3-month trial period, and he's been hospitalized maybe twice with pain crises. So I think there's a lot of evidence moving forward that maybe this is what we need to keep us healthy. I don't know if he's taking his hydroxyurea historically. I mean, he does not like taking pills. I know that about him. And so that in and of itself is a risk factor for not being adherent. But then there's consistent evidence that suggests that he does not take his medicine. So that's kind of what we're teeing up. He's in the midst of a very intense hospitalization, but starting to plant seeds around how do we this is not sustainable being in and out of the hospital. But developmentally, right, he's invincible. He's 18. He knows best. And so I think that this was the best compromise we could come to in that moment, that we don't recommend this, but if this is what you want, we'll trial it and see how it goes. So I think we're getting ready to have big conversations outpatient once he is out of the hospital. All right, any other questions before I move into kind of how I've approached treatment wise with him? All right, I will move forward. So my treatment, like I said, has been alongside medical visits, and during hospital visits, I go inpatient and outpatient and follow patients where I go. So I do a lot of 3 different types of evidence-based interventions, which some of you all, I'm sure, are familiar with these. So I do a lot of cognitive behavioral therapy, especially with his age. Cognitive behavioral therapy and what's called acceptance and commitment therapy both have a lot of research and evidence. ACT is a little bit more new wave, but it still has a lot of evidence with kiddos with chronic conditions and being effective. So as far as cognitive behavioral therapy, there's a lot of principles around connecting cognitions and emotions and behaviors, and how those drive, cognitions can drive behaviors and emotions. And so he says, as I mentioned, he says a lot of things that are very unhelpful or maladaptive cognitions that he's learned over time, kind of this learned helplessness. I can't do anything when I'm in pain, or there's nothing I can do to make this situation better, to be successful, really extreme, that are really ultimately unhelpful, and kind of fuel that depressive cycle. And so I do a lot of cognitive reframing with him around, he'll say, I can't do anything when I'm in pain. Oh, hold on a minute. Last time when you were here, we used this skill, active distraction, and that was helpful, right? And so really kind of reintroducing him to relaxation skills and pain coping skills, and then using that evidence to later help him reframe these unhelpful thoughts. So any questions about cognitive reframing or what that looks like?
I
Okay.
guess just a question on how you sort of frame it, because sometimes, right, when we try to reframe things, patients may take offense thinking we're not, So any tips you have on how you frame it with them?
I always, it is touchy if you don't like kind of set yourself up correctly. I do always, just as a basic spiel, with any of my kids with sickle cell disease, I talk about the relationship between the biopsychosocial framework of sickle cell, and that we know that, I'm here and I have a job because mental health impacts sickle cell disease and how we manage your sickle cell disease and your outcomes. So I always frame everything I do from the moment I walk in the room. That's how I set the stage for myself, that I'm here because mental health impacts treatment and your disease, and there's things we can do to help with that. So I think laying that groundwork can be helpful, and then constantly kind of reflecting on, we know that when your mood is low or you're feeling hopeless and helpless, that makes your perception of pain greater. And so really just always linking it back to emotion, kind of how you're thinking about things. Your pain is real, and your pain gets louder when we feel like it's all out of our control. Did that answer your question?
Yep, thank you.
Yeah. Always validate that your pain experience is real, and I believe you have pain. And there's things we can do to kind of turn down the volume of that pain. So I use a lot of cognitive reframing with him because he has just such extreme cognitions that are kind of rooted in hopelessness and helplessness. Again, very classic depressive profile. I also use a lot of behavioral activation, particularly when we're in the hospital. So behavioral activation, I work closely with our physical therapy partners that, what movement goal, how can we get this kid out of bed? Not only is that good for your physical health, but it's good for your mental health. Being stuck in a bed is not good for anybody for a multitude of reasons. So working closely with PT to set appropriate movement goals throughout the day. And then active distraction. So distraction is thrown around a lot in a hospital setting. Research and evidence shows us that active distraction, so not just scrolling on our phones, right? I have so many kids who say, what are things you can do to keep yourself busy in the hospital? And they all pull out their phone or their tablet. And so I say, well, I give education around active versus passive. So active is, again, something that really engages your brain and makes you think. So if we really have to use the phone, let's play a game on our phone that requires some interaction, or let's play a card game. So there is a lot more evidence to show that active distraction helps with pain coping. And then last, I teach relaxation skills in the hospital and outside of the hospital. I do want to say, and I know my time, I got to watch my time here, but I wanted to share, I've done a lot of guided imagery with this young adult. And he has so much insight and such a beautiful kind of visualization that he uses when he's feeling particularly defeated. So he's a boxer, like I said, and so his guided imagery, I will guide him, and now he can do it independently, but I'll guide him through a time. I first coached him, tell me about a time when you feel most powerful and most strong and most in control. And he said that is in the boxing ring, and his opponent is his sickle cell. And so using that visualization to help give him a little bit of control and confidence as he's in the hospital and really struggling with pain. And he just does such a beautiful job. Someone who you wouldn't maybe target with that would engage so well, a teenage boy, they're not usually my typical audience for guided imagery, but he engaged so beautifully and was able to kind of really get some power and confidence. And he goes back and he uses that strategy when he feels really overwhelmed about his sickle cell disease. So I just thought that was a really beautiful and just so much insight that he had. So the other two strategies that I use with him, a lot of MI, and I'm sure a lot of medical partners on the call use MI, but essentially helping him evoke motivation for change. And this ties in with acceptance and commitment therapy, trying to identify what is most important to him and how do we link healthcare goals with what is most important to him. So his values, he wants to be a boxer and he also wants to be a dad. Those are two really important things for him. So how do we discuss reaching those goals and, with healthcare decision making. That's a little bit more of what we're doing right now as he's getting to a more stable place. His pain is a little bit better managed in the hospital right now. We can have some of those bigger picture discussions, again, setting up for the clinic visit that I'm sure will be happening soon, to discuss what are we doing, going back on exchange, hydroxyurea, what's going to be how we manage your sickle cell disease. So ACT is a lot of exploring values and helping him commit to values-based actions. So you say you want to be a dad. So how can we support you? If you want to be a dad, you have to be alive, number one. So how can we keep you alive and help you reach that goal?
How does he put I mean, obviously, if you're a boxer, you're going to have more pain from boxing and increase your risk of secondary complications in addition to his sickle cell disease. I don't know how he puts those things together in the same place.
Yeah, I think that's really interesting. I think there's a lot more exploring. I think he is still, as much as I work to reframe some of his cognitions, that core belief, and I think those core ideas about himself is not integrated with sickle cell disease. Sickle cell disease is outside of, it's the opponent. So I don't think he still has a really solid integration of, sickle cell disease is not all of him, but it is a piece of him that we have to think about. I think he wants to envision, I'm a boxer, I'm a dad, I'm a partner, not this piece of him that keeps popping up. I think denial. There's a little bit of denial and not wanting to fully integrate that into who he is as a person. So I think there's still a lot of work to be done in that regard. Yeah. All right, I have some questions that I would love to pick your all's brain about. I threw up on this last slide. So the first question, there's a lot going on with this kiddo. Medication adherence is a concern, mood, anxiety, which impacts adherence, but also can be helped with adherence. I worry about neurocognitive functioning for him as well. Just his ability, his executive functioning ability to work towards, set and work towards goals. So what would you all prioritize in treating him?
So I personally would prioritize getting his sickle cell stable with transfusions. It sounds like that's the one thing you can take off the table is you can deal with his sickle cell disease, and he doesn't need to have a port unless you really can't get peripheral access. I know U of L does a lot of automated exchanges, but we can do it in other ways without a port. So I would do that because if you don't stabilize a sickle cell disease, it's going to be hard to convince him to do anything else. And I would really pay attention to not using stimulating opiates because that's not going to help anything. Those would be my thoughts.
Right. Yeah. And I think the conversation of peripheral IV has come up quite a bit. He had to be transfused in the hospital. He does not like needles. He gets very anxious around needles, but I think so the thought of having a peripheral IV, he's not crazy about. But I think, here are your options. This has to be the case. Here are your options within that. I think one of the things I'm most curious about, so I'll jump so we're not short on time, is how the second two questions are what I'm most curious about. So how might you approach transition? So he's 18, he is out of high school. He's going to be on the docket in the coming year or two for transition. How are there any special considerations or thoughts you all have about approaching the transition conversation or even, the process for him?
Come on, I know a lot of you all have thoughts. Stop being quiet.
This is Bainfu here at ECU. We would have similar patients like that. I think the first question is really what are the options of adult sickle cell care? and what will they be able to offer, right? So if they will not be able to, let's say, start transfusions now, would they be able to offer that? Can they do the peripheral sticks? Sometimes the pediatric nurses, most of the time, we are more accommodating. We have nurses who are more willing to take people who refuse to get stuck or play around before you stick them. Do you have the type of support in your adult center? I would think this time is really trying to make sure what you are setting up long term is something that the adult sickle cell center can continue to do. Otherwise, he will have to just start all over with what the procedures would be there. But I, as a pediatric hematologist, I struggle frequently when people are adults and they make these decisions that are contrary to their interests, but they are their decisions to make. But I would explore what the adult center would offer once you transition them and try to work him towards that type of management model.
And I think thinking of that, there is an adult social worker. And I believe they're a licensed clinical social worker, but just with his significant mood concerns and how that might impact his adherence, I worry about mental health management on the adult side. He is not one who's going to go see a therapist in the community. He just does not have the resources to be able to do that. So yeah, that makes me nervous for him. But what other considerations with transition?
Hey, I had a quick question. I'm Santana, at the UAB Sickle Cell Clinic. I was wondering, do you have like a resource, I guess someone that does what you do for him currently that he could that you're familiar with, that you can all, kind of have as a point of contact. That way, when he does make the transition, you are that point of reference. Do you already have that in place, or that would be my main question? Because it seems like you've been a great help for him. So that little tidbit of kind of familiarity might help make his transition might be a little bit smoother.
That's interesting you say that. We recently discussed this. We're ever tweaking our transition process. And I started doing a psychology transition consult to kind of with all of our kids going to adult care, and then I will forward that onto the licensed clinical social worker on our adult side. That's if they stay within our system. And we had talked about especially for the patients who I am very closely aligned with and have worked, really closely with a lot of mental health issues, should we have him even come over and meet them with me, maybe doing like a co-treatment type of session, so that I think so much is rapport building and relationship building with this population and our kiddos who have been through so much trauma. I like that idea. Really trying to align myself with or align the adult social worker with me. I see in the chat someone asked if he was employed. That's something that I haven't been I haven't pushed too much. One of our nurses inpatient got really curious and was asking him a lot of questions. And he is not employed. I know he's not. He's graduated, but he's not employed. And she was asking, kind of probing. And it just sounded like there was questions I maybe didn't want the answer to. And so I have not explored that further with him.
So unfortunately, we do have to move on to our didactic. This is a great case, and I think one we should continue discussing. And I think, at least from my thoughts, I would transition his medical care to something stably first before you transition him to an adult provider, right? And you can do it in parts where perhaps he sees the adult provider but still comes back to see you intermittently, who he trusts, or that you go with him to see the adult provider.
I like that idea.
To help establish trust. We do it all in the same room in the beginning. So we go see the kids at Children's with our social worker and the ped side. So we're all in one room. And that does at least help bridge trust. I think at least my only other thought is, obviously being a boxer is not a long-term career for him. For not just because of his sickle cell disease, but it's like being a football player? How many people actually make it to the NFL? So some suggestions would be, I don't know if you have Voc Rehab or other options, but could he be a coach? Could you help him learn to be a boxing coach is something that would be still empowering to him, not take away from his power, but I would be real and honest. It's like all my patients who tell me they want to go in the military. We have very honest conversations about that's not going to happen.
I just recently broached that with him the other day in the hospital. I said, okay, well, how feasible is that? So I think that's a great idea too, transitioning that to a coach of some kind. Yeah. Yeah.
But
Thank
that
you
was
all.
really a great case, and we'll look forward to some follow-up in hopefully a couple months.
Yeah. Thank you all for your thoughts. I appreciate it.
All right, well, moving right along. Perfect, because we're going to talk about exchange transfusion. So that was nice to have that bridge. I'm excited to introduce Jackie Lomax, who's a nurse with the Red Cross. She's actually been working at the Red Cross since 1996, and she's been performing therapeutic apheresis since July of 2003. And she does a lot of work with our patient population down in the southern part of Alabama, where she performs therapeutic apheresis on individuals ages 6 to 60. And I will turn it over to you, Jackie.
Hey, Dr. Cantor. Let me share my slides. Now this worked seamlessly earlier. Now I cannot. Oh, there we go. All right, so as Dr. Cantor says, been with the American Red Cross since 1996, have been doing therapeutic apheresis full-time since 2003. So we're going to go over the indications for exchange transfusion depletion, and I'm going to run over that real quick. Most of y'all know the indications, how the exchange transfusion depletion works, how to adjust the volume, anticipated issues, complications, contraindications, and other related issues. So according to the ASFA guidelines, which is the American Society for Apheresis, every 3 years they put out a journal. This one was published in January 2023, and there's different categories. Usually category 1, 2 are disorders that they've done the studies on, and those are first-line therapies or second-line therapies with some adjunct therapy. 3, you really need to look at what you're doing. Is it really going to be beneficial to this patient? And 4, those are what I call last-ditch efforts. Those are, we've tried everything else, let's try this. They make those categories based on classifications, and most of them are because they've either done clinical trials or it's evidence-based. And some of the clinical trials, when I was studying this, are really small. They were like 5 patients, but most of them are evidence-based. So in acute red cell exchanges, category 1 obviously is acute stroke, which grade 1C is a strong recommendation, low quality evidence, no clinical trials, but they've just done it so often that they know that this works for these patients. Acute chest syndrome is category 2, and other complications like priapism and such are category 3. In non-acute, which would be our chronic exchanges, stroke prophylaxis, which are those kids that have either had a stroke or have an elevated TCD, pregnancy, recurrent vaso-occlusive pain crisis, and then the pain operative management or preoperative management are the people who are coming in for surgery and they want to give them an exchange prior to surgery because they want them to have those nice, healthy red blood cells. Nobody has seen, this is the machine that we use at the Red Cross, and I think a lot of centers use this. I think there's a few that use Amicus maybe and another machine, but this is what we use. So typically what happens with a red cell exchange, and this shows a 2-arm, but Terumo in the past few years has switched their red cell exchanges to where you can do a single needle. But the basis is we draw out whole blood, separate the plasma and the red blood cells, the patient's red blood cells go into a bag. Their plasma and the replacement red blood cells go back to them. So, and this is just a graphic that I got off of Terumo's website of a basic exchange where we remove their red cells and we give them red cells back. Now, obviously, because your blood is circulating, some of the red cells that I take might be some of the red cells that I just gave them. So you just have to keep that in mind. Now, with the exchange depletion, we can actually lower the hematocrit and take off just the red blood cells in the first phase. And in the second phase, we switch to an exchange where we do the exchange where we're taking off their red blood cells and giving them donor red blood cells. And in the next slide, I'm going to show you why doing a depletion, if you can, is more beneficial to them. So this is the basic data that we need. And if you don't know that Terumo has an app that is amazing, that you put all their information in, their sex, their height, their weight, their hematocrit, what you want their goal hematocrit to be. If you know their fraction of cells remaining, what you want it to be, or I'm sorry, if you know what their hemoglobin S level is going in and what you want their hemoglobin S level to be after the exchange. So the results for fraction of cell remaining are highlighted in the green. That's the second screen. And they also give you the calculation for how to figure out the fraction of cells remaining on your own. But it is the desired post-procedure hemoglobin S by the patient's pre-procedure hemoglobin S. So this slide, I love this slide because it shows the difference between a simple transfusion, a manual exchange, and an automated red cell exchange. Both of them provide healthy donor cells. All of them increase the red blood cell oxygen carrying capacity, but the manual and the automated are the only ones where you're actively removing the sickle cells. The automated one, you can automatically manage and maintain fluid levels, which I always keep mine isovolemic unless I am asked otherwise to do. And when you look at the procedure times, everyone's like, oh, this red cell exchange is going to take so much longer. Not really. It takes less time than a simple transfusion. Most of my patients, other than this, my 6-year-old pediatric patient, who we have to run him longer because he's had citrate issues in the past, most people in 2 hours can be done. And your frequency changes because you are removing those sickle cells. Hopefully they're not in pain crisis as often. And so you can actually spread them out further so they're not having to come in as often. So with my acute case, I have a male that he has sickle cell disease, presented for a scheduled red cell exchange, no recent acute sickle cell complications. He's 5'10" and 70 kilograms. He came in with a hematocrit of 30. The hematologist would like to target a hematocrit of 30 with the procedure. For the depletion, we target a minimum hematocrit decrease of 6% from the patient's pre-procedure baseline. So, and I may have skipped one, sorry. But anyway, so the replace volume, he developed shortness of breath requiring oxygen. His total blood volume is 5,000 milliliters. Beginning hematocrit is 30, target hematocrit is 30, and your replace volume is going to be 2,546 milliliters, approximately 7 units. So when you look at, we're going to do a depletion and we're going to decrease him by 6%. So if you're starting at 30, we're going to decrease him to 24%. So here are the numbers. So everything stays the same. His hemoglobin S, we're assuming is 90% because he came in, we don't know what his S level is. We want to target 30%, so that's going to leave his fraction of cells remaining at 33%. So the replacement volume with just an exchange is 8 units, and it's 7 units if you do a depletion ahead of time. Now, I tell people that doesn't sound like a big difference, 1 unit, but when you have patients that have been exposed to multiple units over a lifetime, that 1 unit every month over a lifetime of exchanges or transfusions adds up. And also, if you have somebody that's already has antibodies, they finding that 8th unit is sometimes difficult. Sometimes finding 5 units for them is difficult. So same guy comes in, hematocrit's 25. They want the end hematocrit 30%, and we're going to deplete them to 21%. So once again, you see the difference between a depletion exchange. Usually it's only 1 unit, but like I said, that difference is over a lifetime of units is a lot, especially if they start at a young age getting transfusions or exchanges. So now he's an iron overload. Came in with 25%. We want to leave his end hematocrit at 25%. The reason for that is because if we go up on his hematocrit, we're going to increase his iron overload. And a lot of times we don't know why they're an iron overload. I mean, are they taking their medications? Are they compliant with that? Or are they just, is the medications not working like they should? We did have one pediatric patient that had an adverse reaction to the medication and could not take the chelation therapy. But we're going to deplete his hematocrit to 21%. So once again, it's 1 unit, but like I said, those units over a lifetime add up. And I threw this one in here. This is one of my pediatric kids. This is basically where his pre-hematocrit, his post-hematocrit, what we set the hematocrit on the machine at, his pre and post hemoglobin S levels, his ferritin levels, replacement volumes, and everything. So you can see the difference between what your numbers do. So the depletion exchange that we did in August, you can see that his pre-hemoglobin S came back under 30. We got him down to 8.8, but we didn't do a depletion that time. And then the next time he came in, he was 31, and we left him at 11.3. So I'm going to stay on the slide for a minute. So if anybody has any questions about that particular slide.
I have a question. I was looking at your ferritin. So does this cause them to be a little bit more iron deficient?
Well, that's where you, if you look, like in March, his pre-hematocrit was 33.
Yes, we often cause iron deficiency in this way.
Yeah.
Right. And I know what regular exchanges. So somebody who already has a little bit of iron deficiency, are you worried we're going to make it worse with doing depletion, or do we just supplement with IV iron? Or because it looks like it's ferritin even before you started the depletion, if I'm going sequentially, it was already a little bit low.
Well, and so with the ferritin level, if you leave their hematocrit, great. If you set up the machine to increase their hematocrit, you can actually bump their ferritin level up. if you lower their hematocrit or set it up to be lower or the same, you can actually deplete their ferritin level, their iron levels.
Okay. All right. And then so I'm sorry, just so to understand, because I actually have to write my transfusion orders here. So when you're depleting them, what you're saying in essence is that they're in hematocrit, you're making it lower than starting?
Well, no, you can actually end up with a higher hematocrit depletion. What I normally do, say for him on August, if I wanted to do a depletion, we started off at 33.5. So I could actually say, let's deplete him down to 28. And then at the end of the exchange, I could say, I want his ending hematocrit to be 25%. I can actually raise it back up higher than where we started.
Okay.
Hey, this is Hamayan Imran from Mobile. I
Hey,
just
Dr.
wanted to,
Imran.
add like what Ms. Jackie is stating the way, I've kind of dealt with, for a few patients when they become, iron deficient that, I've, just, kind of, added some pure iron for the time being. And then I had been more vigilant to not, to at least, bring them up to like 30 of the hematocrit if they're lower. And that way, we're giving them iron in the next 3 or 4 or 5 transfusions. We were, we were kind of able to catch it up. My only, sort of understanding for the depletion is that it'll give me a jump start for some of these, children that I'm trying to aim for a lower, sickle, percentage, and that, just kind of gives like a jump start, and that's why, I've added that to some patients.
But hi, sorry, I didn't introduce myself. My name is Joy Venchele. I'm in Florida. Yeah, I totally agree with the in hematocrit. I've heard some people say that when someone has an acute stroke or in that time period, we shouldn't shoot for a hematocrit less than 30. So is it kind of patient specific in terms of their indications of when we try to do depletion exchanges? I've also heard too that with moya, sometimes you have to be careful with dropping their in hematocrit. Would like to see what your practice has been in those cases.
Yes. So we did have a patient with moya. I don't remember what we did with him specifically. Dr. Emmerman might remember, but
We haven't been any more cautious. I'm sorry, I'm also not aware of any literature, that would have made
Okay.
me, do it a little more conservatively. But I do know that, kind of some patients may not be able to tolerate the depletion because that just drops their crit enough that they can have, some symptoms of, kind of hypovolemia, kind of chills and some dizziness. So, I'm other kind of cautious, like for some, but I wasn't aware of anything about moya. We have, at least 3 patients that we regularly transfuse and haven't had a major problem from the crit point of view.
Okay.
yeah, and the literature actually says to not drop their hematocrit by more than 6% when you're doing a depletion. Even for me, but this is pediatrics, I'm even cautious with even that.
I agree though with the concern with moya. We do have several patients who have, I mean, you even deplete them slightly, even you don't deplete them. We actually don't deplete them at all anymore. And even in regular exchanges, we've had several individuals have seizures, several individuals who have episodes of severe hypotension, postural hypotension, and it's really related to poor blood flow of the brain. So I actually think those individuals also need they need to move slower on the pump. But I think there's interesting questions for sure.
Yeah, and like someone mentioned, I mean, so every time I go in, either me and Dr. Emmerman or me and Dr. Maury have a conversation about this is where they're at, this is where we want them to be. What can we do different to have them where we want them to be? But or is working what we did last time worked beautifully. Let's do that again. So it's always a conversation about how that patient does. This isn't the 6-year-old patient. The 6-year-old patient, he is a whole handful, but he's so tiny that I have to make my machine do everything that it will. He's a single needle. We have to do a blood prime. Last time we did a depletion on him, and then we did the depletion exchange, and he actually tolerated it beautifully. And I was really, really nervous about how he would do for depletion. But like I said, we did the blood prime, which we always have to do because he's so small, but he tolerated it fine. And I was really shocked. So this is my disclaimer page. The side effects can include all of this, but mostly your common side effects are hypotension, hypovolemia, because the extracorporeal volume of the kid is 185 mils. So if you have someone smaller, you have to think you're taking off 185 mils of their circulating volume, and it's going to be in that machine the whole time. Citrate toxicity, which is the main thing that I see with the numbness and tingling of the lips and fingers. We can give Tums for that. We can give calcium gluconate or calcium chloride for that. And then of course you have your transfusion reactions, and you have transient reduction in their platelet count. Contraindications, obviously, if they're hemodynamically unstable, you don't want to put them on a machine because, once again, the extracorporeal volume is 185 mils. A lot of our barriers are vascular access. If they don't have good enough veins peripherally, available units, we have some that they're just so hard to type and cross. To get 5 units even is ridiculously hard. Like, it takes a day or two to even get them. Like I said, though, thankfully Optia now has a single needle red cell exchange, so we only have to have that one port or that one good vein. And obviously you cannot deplete them if you have a low starting hematocrit, which me and Dr. Cantor discussed. One of the mobile infirmary patients, that she has 0 wiggle room because she starts off so low.
Yeah, I think that single lumen option is really something that's going to be a game changer for us, and something that we have to talk about as a sickle cell community as well, because it actually relates to the case we just heard, right? Using single lumen, this patient may not need a port. He may be able to get an ultrasound guided IV for each exchange. And so that might be an option for that individual. So I think that these are actually going to be a conversation this year at the Alliance meeting. Is going to be coming up with some new sickle cell and transfusion related guidance, because everything that's been done has been done by ASFA and not by the sickle cell disease community. And so we want to make sure some of those indications are seconded and available through a joint effort between sickle cell and the American Society of Apheresis. So that should be coming soon to your inboxes, but something that we're looking forward to. And I think this is fantastic and super helpful, and really thank Jackie. And again, I don't know anybody heard, but Jackie is part of the Red Cross. And so in places where we don't necessarily have their own independent apheresis, we can actually bring the Red Cross in if you get a contract with them in your hospital. And so it's been hugely successful for the for both Mobile Infirmary, but also more importantly for USA and Mobile. So something that's really exciting and an option, and things we can also talk about. I do have an unfortunate announcement to make due to the fun federal things that are happening. Not because of the funding issues, but because of the can't have public conversations with a group issue, even though HRSA is not on this call and not part of this call. I don't know. I'm getting the guidance that we're going to have to cancel our echoes for 3 weeks and should be able to resume in 3 weeks. As soon as we can resume, we will be letting everybody know. Again, this isn't a funding concern. It has to do with whatever the public grouping meeting thing is, even though no federal agents are on this and we're not expressing any federal opinions. This is what I'm told to tell all of you. So that's where I got. Any questions about apheresis, depression, or federal funding? Preferably not the latter.
Quick question, Bang Fu here, ECU. You mentioned this single needle option. Is that widely available? Because I would like to use it like next week or tomorrow.
Yes, it
Oh,
is,
my
and it's
hospital
been
should be able to-
poorly, yes, and poorly disseminated, Bang. That's one of the things actually we're looking at. Yes, it's widely available. It's on the Terumo website, and I'll connect you to somebody in an email in the next few minutes.
Wonderful.
Yeah, and it's just as long as your Optia is programmed to do a single needle, there's a single needle adapter that you can buy from Terumo that you just hook both your access and your return both to the single needle adapter, and the machine just does it.
All right, wonderful. I will talk to our team tomorrow so we can start. I mean, that is a big game changer in my opinion.
I think it's a huge game changer that's gone somewhat under recognized, and that's why we wanted to bring it to the Alliance meeting this year. So I totally agree with you. And
Yeah,
as I said, I'll connect you to some people in the Southeast at least. And I don't know that they're your person through Terumo, but they can connect you to your own person.
yeah, we have it here and it's been amazing, very much so. Yeah, I definitely agree.
Yeah, and Terumo is an amazing resource.
They really are. I concur.
I call them a little too often sometimes.
All right. Well, thanks, everyone. It sounds like we'll see everyone in 3 weeks. If I get additional guidance sooner, I will let you know. As I haven't heard anything about shutting down support, I'm going to pretend like we don't know anything about that. And we were just told to shut down this echo. So for the moment, that's what I'm going with, but we will send out additional guidance as it comes to us. And I wish everyone the best. Stay sane.
Thank you.